So are the slides visible?
Yes.
Okay,
Yes.
good. Thank you. So today's lesson will be, it's about pharmacist's role in patient safety in general. So this is the continuation of last course. So after the end of this lesson, I will define what patient safety it is and some terminologies related to patient safety, establish an understanding of sources and contributing factors for patient harm, discuss the epidemiology of medication-related harm, and common types of medication errors, and the impact of medication pharmacists on medication errors, and at the same time on some clinical outcomes. Medication errors are kind of process outcomes, but we'll also discuss some hard outcomes like the impact on hospital readmission, the impact on mortality, the impact on some clinical markers like a decrease or an increase blood pressure, something like that. So we'll also look at that. So to achieve these objectives, I have outlined my presentation in such a way that we'll define patient safety, source of patient harm, common types of medication errors, with some examples, and finally, we will see what's the role of pharmacists in improving patient safety. So you can drop any questions if you have at any time, you see. So you don't need to be shy. So patient safety, what comes to your mind when we talk about patient safety? I think this is not a new word for you as far as you are a pharmacist. What comes to your mind when we talk about patient safety? Yeah, patient safety, meaning that it is about preventing people or patients from harm, yeah? Free from harm during the patient care process. That's what we call it, patient safety. So the WHO World Alliance for Patient Safety defines patient safety as a reduction of risk of any unnecessary harm associated with the patient, during the patient care process. That is unacceptably minimum. You can't avoid, you can't make it zero absolutely, but at least it's the minimum. It's the minimum that we call it patient safety. So medicine safety, that's is a subset of patient safety. You see, yeah, that means that patient safety is a broad term, yeah, and medicine safety is a subset of patient safety. So do you know that any other things other than medicines that can harm patients? Maybe say some examples of harms that can be caused by non-medicine issues. Like?
Lassa.
Sorry?
Look like, sound like medicine.
Yeah, like what? I mean, other than medicines, like other things. Other than medicines, what can cause harm to patients? For example, surgery. Yeah, patients can be harmed with surgery. Patients can be harmed even with infections, hospital-acquired infections. So this is harms that may not be due to medicines. So patient safety is a broad term by itself, but medicine safety is safety related to medicine use. So as usual, before going in depth to patient safety, let's take a look how we progress with the improvement in patient safety across the world. This is the first report, 2-year is human report by the Institute of Medicine report from America, which highlights the problem of medical errors. As high as 98,000 deaths occurred annually because of medical errors. So this is the first report that galvanized the medical community for patient safety initiatives. So this is really a huge number at that time, even, there are more deaths annually as a result of healthcare than from road accidents, breast cancer, and AIDS combined. So this is a data from 1999. So this is a very important report. So with this report, it proposed a number of changes to the culture of hospitals, like no blame culture for the staff who make an error. Yeah, blaming culture does not change significantly a decrease in patient harm. So this is one of the suggestions by this report. Rather focus on patient safety as a whole in the patient care process, meaning that system-wide change in the way patients are treated, maybe the way patients are cared, is the major thing that we should focus. That's the major change proposed by this report. And a number of recommendations for hospitals have been given, like establishing patient safety centers, implementing some reevaluation mechanisms, paying attention to safe use of medicines, and designing reporting systems. Currently, many hospitals have reporting channels in place. So this comes from this report as well. Safety as a focus is also safety has got attention from this report onwards. So as I've said, the first report that gives an impetus to the safety initiatives worldwide is the 2-year is human report. There has been a number of reports across the years, but surprisingly, they didn't show any decline, any improvement in patient harm. So, specifically in the first decade after the first report, there has not been any improvements in patient safety. So a number of changes have been made across hospitals in the USA. As usual, USA is a role model for a number of things. So this report is majorly comes from the USA. So because of no change in patient safety improvement in the first decade after the first report, the Institute of Medicine report, a number of changes have been endorsed in different hospitals in America, so that there has been some kind of improvement in the last one decade. But still, it needs more improvement, further improvements, like, for example, hospital-based infections. Implementation of safety tools and practice is considered inconsistent. And recently, have you heard that the third global patient safety challenge, medication without harm? Have you heard? How many of you have you heard? Drop on the chat box yes or no. How many of you have you heard of the third global patient safety challenge, which is medication without harm? Have you heard of this? Yes or no? I can't see your message. Yes, 1, 2, 3. Okay, 3 out of 6 people, is that? 3 out of 6 people have heard of the third patient safety global challenge, which is medication without harm. So, yeah, look, because of the global burden of medication-related harm, this global initiative has been endorsed by the end of 2017. So now it's a global challenge which many nations in the world have adopted in their health policy to make sure that avoidable medication-related harm should be reduced by 50% or by half over 5 years. So the frame for over 5 years is different from countries to countries because it depends on at what time they started their policy implementation. So it matters from country to country. But the aim from the WHO is that to reduce avoidable medication-related harm by 50% over 5 years. And the three flagship elements under this medication without harm challenge is polypharmacy, transitions of care, and high-risk situations, including medications and patients. So there has been a number of resources, which I have also been part of this grand challenge with producing some technical reports on medication safety. Okay. Oh, sorry, stuck. Okay. Okay. Let's see some data from Australia regarding medication-related harm. Specifically in older adults aged 65 years and older. Medication-related harm in Australia resulted in 250,000 hospital readmissions, plus 400,000 emergency department presentations. So this is equivalent to, or it costs the Australian healthcare system $1.4 billion per annum. Surprisingly, 2/3 of this medication-related harm are preventable. So there is a potential for pharmacists to engage in reducing such harms. How? We'll see later. There are also a number of studies I have been involved with how medication-related harm, or specifically potentially inappropriate medication prescribing, is associated with some clinical outcomes like hospital readmission, mortality, functional decline of functional outcomes. For example, the first systematic review and meta-analysis I have conducted shows that potentially inappropriate medication is linked with medication-related hospital admissions, functional decline, economic cost, and adverse drug reaction and adverse drug events. And in sum, when summed with all the findings together, there's an underdiagnosis with regard to medication-related harm. And this may be due to, we have suggested a number of things why medication-related harm is underdiagnosed in the Australian public hospitals. Maybe because, physicians may not differentiate the clinical manifestations of the disease versus the medicine. So that may be one of the reasons. And at the same time, it may be difficult to differentiate from the underlying aging process. Sometimes, aged people have a number of geriatric syndromes. We call them geriatric syndromes. Those geriatric syndromes resemble some of the symptoms or clinical manifestations associated with medication-related harm. That may be one of plausible reasoning. Another is under recognition of risk by the prescribers and use of multiple prescribing protocols. Usually a single patient may be treated by different physicians. In one hospital, he or she may be treated for some disease, in another hospital maybe for another case, and in the family practice for another case. So a combination of these multiple prescribing protocols when applied on a single patient, and when the team or this multi specialty teams across the different settings didn't discuss together, you can't preclude medication-related harm in such situation. So this may be the reason as well. So yes, we need to define some terminologies before going into medication errors, some specific medication errors. So adverse events. Adverse events mean that it's anything which is unfavorable or unintended that's occurred to a patient during the patient care process. It may not be related to the medicine. It's anything which is harmful for the patient. So this may be expressed by an abnormal sign, an abnormal lab, symptom, this whatever. So it may be related to a disease, it may be related to the medicine, it may be related to something else. But when this abnormality is due to the medicine, we call it adverse drug events. So adverse drug events are adverse events due to medications. So these adverse drug events again divide into maybe they are due to adverse drug reactions or medication errors. Okay. One thing I wanted to clarify here is that terminologies may differ from a number of terminologies you may encounter from the literature, but what I have described here is the most commonest terminology used among the patient safety advocates and researchers. So you may come across a different definition when you find out over Google or somewhere from the literature. Adverse drug reaction is an unpreventable adverse drug event. It's an injury due to a medication where there is no error in the medication process. This means that this event or this harm is caused due to the intrinsic nature of the medication. It's about the intrinsic nature. It's not about medication error, but it's occurred because of the nature of the medicine. That harm comes due to the nature. For example, anaphylaxis, anaphylaxis reaction for a patient who is not previously known to be allergic to a medication. So in such a case, we call it adverse drug reaction. Preventable adverse drug event, that's the opposite of adverse drug reaction. It's an injury, that's the result of an error. It's an error at any stage of the treatment process. Medication error, it is unintended failure in the treatment process that leads to or has the potential to lead to harm to the patient. So medication error may result in harm or not. Yeah, so let's show you the relationship between medication errors, adverse drug reactions, and adverse drug events. This is the commonest terminologies employed by the patient safety literature. So here the basic thing you have to know is that adverse drug reactions are not due to errors. They are due to intrinsic nature of the medication. And preventable adverse drug events are due to medication errors. Medication errors may result in harm or not. Okay, source of patient harm. Yeah, all errors can be classified into two groups. The first is active error, or what you call human error. as individual error. They are active errors. They are committed by the staff, by the healthcare professionals. They are individual based. The other is system errors. Okay, same example. For example, giving the wrong medication and treating the wrong patient or the wrong anatomical site, for example, in terms of injection site, not following the correct policies or procedures. The other errors are latent or system errors. These are errors that occur due to a set of external factors. It's not about the individual, it's not about the person in focus, but it's about external factors or indirect failures involving a number of things like policies, protocols, organizational culture, knowledge transfer, that means communication across the healthcare organization, maybe across the healthcare professionals, maybe. So it's all about external factors or system-wide issues. Understaffed wards or inadequate equipment. These are examples of errors that occurred due to system or they're latent by themselves. But surprisingly, these are the major errors. I mean, and the one which we can modify mainly. You know, there are people who we call them human factors researchers. They try to change the way the organization is, for example, designed to improve patient safety. So, you know, there are a number of fascinating researchers around this, how we, for example, redesigning the system, redesigning the way patient is cared, or the way offices are organized, or the way the patient is passed through the hospital can be redesigned so that they can reduce a number of medication errors. So these are latent errors, but they have very important impact on patient safety. So the choose model shows that medication errors are due to two factors. One is active errors or human errors, that's individual-based errors. Another is system errors or latent errors. The latent errors are failures within the system. You know, there are some holes. Have you seen these holes? These holes show that there are always holes within the system. There are some breaks in the system that can expose patients for errors. So this should be filled up, or should be filled with some kind of intervention so that errors can be reduced. So this model shows that errors can be latent factor. It may be due to latent factors or active failures. So have you seen here, for example, defenses? There are a number of defenses, for example, to fill up these gaps. One is pharmacists, for example. If there is no any pharmacists in the ward which can fill up those gaps, because pharmacists are a defense systems, they are defense systems for this holes. So the patient may be exposed for errors. What are the most common errors you have encountered in your practice? Can you elaborate some errors you encountered in your practice? Feel free.
Read the prescription, maybe.
Okay, one thing. Yep. You're right.
Because not use the electronic prescription, is manually.
Yep. Errors due to that comes due to even electronic prescribing errors are there. Yep. Another errors you encounter?
Maybe about last prof, because look alike and sound alike, then it becomes poor drug management.
Yep,
So
yep.
we can take wrong drug.
Yep. You're right. Yep. These are some examples, and when we classify, for the sake of this presentation, stuck. Yeah, I have classified the types of medication errors, including medication. Actually, medication reconciliation is not an error. It is a strategy used to identify medication documentation errors or medication history errors or medication discrepancies. Anyways, these are another groups of medication errors. So medication reconciliation, you can say maybe errors due to failure to reconcile medicines, or medication reconciliation errors, or medication discrepancies. Yeah, we can give a number of names for this anyways. So any errors from failure to reconcile medicines, that's one of the types of errors. Another is prescribing errors, transcribing, dispensing, administration, and monitoring. Among all these errors, the major types of errors are prescribing errors, errors due to failure to reconcile medicines, and medication administration errors. These are the most common errors in the literature, and actually practically as well. So we'll go one by one anyways. So can you classify what kind of medication error is the first question? Read it and give me a suggestion. What kind of medication error is that? The first one, aspirin and clopidogrel seized in ICU and not recommenced when the patient transferred to ward. What kind of error is this? Yep, it's prescribing error. Yep, thank you. It's prescribing error. And the second question, patient prescribed Rampril 1.5 milligram daily. Medication chart was rewritten as Rampril 12.5 milligram daily. What is this again?
Reconciliation.
Patient prescribed Rampril 1.5 milligram daily. Yes, medication chart was rewritten as Rampril. So it may be, it depends on here, maybe dispensing error or it's documentation error. It depends on the person who writes this one. It depends on the person. It may be documentation error or else it may be dispensing error. Yep. The third one, patient initiated on new cardiac medication, discharged with no summary or medicine. Sorry?
Maybe reconciliation.
Yep.
Not documentation.
Yep. So there's a discrepancy. So yep, it's related to omission actually. So it's part of, yes, medication reconciliation. Sorry. Okay. So let's come to medication reconciliation. Transition of care, usually admission or transfer within the hospital, or even transfer from patient, from nurse to physician, or from nurse to nurse, from physician to physician, and from discharge to home, discharge to residential care or nursing unit. So these transitions are usually very risky areas. So because usually there is a discontinuity of information transfer. So this is very risky areas. So unintentional changes to patient's medication regimens represent one important category of such errors. So this is very important from the perspective of continuity of medication management. Medication management pathway. So yeah, this shows that the pathway in which medicines and patients are engaged. So this shows a transfer of information across the different stages of the medication management pathway. Any disruption in information transfer can result in discontinuity. So continuity is an important thing. Continuity is very important. When we see the data, up to 67% of medication histories contain at least one error. These medication histories are because of a problem in transfer of information, because of problem in transfer of information. Incomplete medication histories at the time of admission have been cited as the cause of at least 27% of prescribing errors in hospital. The most common is omission. Around half happen at admission or discharge. Yeah, that is the very risky areas. Admission or discharge are very risky areas. Although these medication errors are abundant, but only 30% can cause patient harm. Yeah, because many may be trivial, but still around 30% can cause patient harm. So that's why we need medication reconciliation, because this is it's a strategy to identify any unintentional changes, so it will fill up the gap in medication discontinuity management. So it's very important to identify unintentional medication discrepancies and avert from continuing omissions or some kind of unintentional changes. So medication reconciliation is a process to reduce adverse medication events by ensuring patients receive all intended medicines, mitigates common errors of transcription, omission, commission, duplication. Commission means adding a medication which may not be needed. That's commission. That's unnecessary medicine, meaning it's unnecessary medicine. Ensure accurate, current, and comprehensive medication information follows patients on transfer and discharge. So there are 4 steps for successful medication reconciliation. The first is carrying out comprehensive medication history. Yeah, many healthcare professionals take medication history, but it may not be comprehensive. Comprehensive means that it's taking medication history using more than 2 and above resources for medicines. Not only the patient, but you should refer a number of resources what the patient is taking. Confirm the accuracy of the history. That's the second, because sometimes the medicine may be stopped intentionally. So intentional medication discrepancies are rational. It's rational. They are not errors. So we need to confirm that. Compare the history with prescribed medicines. That's what I mean. supply accurate medicines information. That means once we make sure that the medicines are the right medicines, we need to supply medication counseling for the patient. So yeah, the best possible medication history, use at least one other source of medicines information to verify. That means to end above medicine resources should be available for the pharmacist or whatever healthcare professionals to conduct medication reconciliation. More comprehensive than just taking a primary medication history. It's more comprehensive. That's, we call it best possible medication history. Yeah, so the source of patient information, meaning the source of medicines information may be the patient, maybe career interview, maybe other source of medicines information, for example, community healthcare provider, community pharmacy, even discharge summaries, previous discharge summaries, previous follow-up or patient chart review. So yeah, we can take a number of sources into consideration when we conduct the best possible medication history. Confirm, just to check that whether it's intentional or unintentional. So we need use another source to confirm this one. Even with the, just you don't need to go to even with the medicines information resource. Even with the prescriber, you need to check. You need to check with the prescriber as well. So these are some source of medicines information. As I said, the patient career, GP medication list, the patient medication list, community pharmacy, residential aged care facility medication charts, patient's own medications. This means medicines the patient brings to hospital. Previous discharge summary. So these are some of source of medicines information. This is the confirmation step with the prescribed medicines. Then supply, that's the final stage, supply medicines information. So let's take this case and then answer the following question. What types of intentional or unintentional medication discrepancies have you identified? Have a look for 1 minute, or for 1 or 2 minutes, and what types of intentional or unintentional medication discrepancies have you identified? You can pop up your answer on the chat box, or you can talk. Have you identified any unintentional medication discrepancies? If so, which medicine? Be reminded, the medication reconciliation is being conducted at discharge. That's why I put here discharge medications. So I'm imagining the medication reconciliation is now being conducting at the level of discharge. We do have medications on admission, and we do have discharge medications, and I'm checking whether any kind of discrepancy or not at the level of discharge. Have you seen any kind of discrepancies? Any errors of commission, errors of omission, discrepancies in error, I mean in frequency, whatever. Can you see any kind of discrepancies? Okay, guess one from the discharge medications. Okay, so for example, how many medicines are there here at discharge? 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4, 5, 6. So is there any difference between the medicines at discharge and medicine on admission? If yes, which? Yes. Yeah, the answer is yes. For example, okay, let's check. Yes, that's it. Yes, there is a difference. For example, have you seen this one? Omeprazole, this one, 20 milligram daily, but not prescribed on admission. So this medication, it may be prescribed in during the hospital, the inpatient care. So it may be it may continue at discharge, but it may be unintentional, because usually proton pump inhibitors are usually discontinued at discharge unless there's a clear need. So we need to check this one whether it's really an important medicine or not. So this may be. Still, we need to confirm. That's the confirmation stage. Still, we need to confirm whether this medicine needs to continue or not. But it may be likely it is commission, errors of commission. Another is, have you seen atorvastatin? Atorvastatin replaces pravastatin. So this is not a problem. It may not be a problem because it's only shifting from the same starting group. So I don't think this is a problem. Another maybe, have you seen this aspirin and clopidogrel? Yeah, these are drugs from the same group. Yeah, usually there are at times when they are prescribed in patients, usually for critically ill patients, or dual antiplatelet therapy may be in need for some critical cases, but it may be not necessary for people who discharge to home on this medication. So we need to check whether clopidogrel is necessary or not. So this may be as well errors of commission, maybe. So we need to check. Others, Lantus with insulin, it's brand shifting, so it's not a problem. Metoprolol, carvedilol, it's a shifting, so it's not a problem. Linzoprin, hydrochlorothiazide, this is a combination and then split down, so it may not be a problem still. So with these two medicines, we can identify some unintentional discrepancies, maybe. So we need to confirm still. But the others, like pravastatin with atorvastatin, this is intentional. Metoprolol, carvedilol, we expect that it may be intentional. We can talk about these things. So intentional means that the physician decides that's the right choice in agreement with the patient. So oh, sorry. What is that? Okay. Okay. So intentional means that it has a rationality for prescribing that medicine. Okay, let's go to the second. Prescribing errors. Yeah, prescribing errors meaning that errors occur at the level of prescription of medicines. So it may be due to inappropriate drug selection. For example, the medicine may be it's a medicine contraindicated for the patient, like pregnancy, renal failure patients, inappropriate drug selection. I mean, inappropriate drug or drug dose, like miscalculation of the dose, or prescribing a drug without an indication. That's unnecessary medication. That's unnecessary medication. Meeting to prescribe a drug for present indication. This is omission. This is a kind of omission. Duplication of drug from the same class, and prescribing writing errors. That's from eligibility. From the eligibility point of view, that can also be causing prescribing errors. Okay, I'm sorry, I think I missed someone. Okay, the other is medication administration errors. These errors mostly involve nurses, patients, and caregiver.
Excuse me, sir. I have a question about reconciliation.
Okay, great.
What the reconciliation method are most effective for retrieving drug and disease information? Because usually most inpatient are those who come to the emergency room at first, and after the emergency room going to inpatient room. Whether the information is taken while in emergency room or when the patient enters the inpatient room.
Yeah, that's a very important question. It's a very important question. Yep. I have maybe I will describe this one later. Usually the practice, the usual standard practice is, and even the high fives. There's a project on medication reconciliation from the WHO as well on high five. It's high five project, 5 high five projects. Among them, it's medication reconciliation. So even with that policy, it says that medication reconciliation should be conducted at the level of emergency department, usually at the level of medication. I mean emergency department. But it's also, it may differ from country. I'm not quite sure. But for example, in case of Australia, discharge area is very important area. In addition to the emergency department, because there are a number of changes made at the level of discharge. So we need to check that whether patients are taking the right medicines or not, as compared to on admission. So discharge area and the emergency department area are very important areas, because the entry and the exit areas are very important. I know there may be a lot of change within a hospital level, but because there is extensive care by a number of professionals in the hospital level, it may be difficult to do the reconciliation within a hospital transition, because a number of changes every day, every hour, every maybe 6 hours, so it's difficult to manage these changes. But it's possible to make sure that the patient was receiving the right medicine at the level of admission and at the level of discharge. These are very important areas. Clear? Have you got my answer?
Yes, thank you.
Okay.
Because it's difficult. In my place, it's too difficult to take the information in emergency department. Yeah,
I see.
There's no many pharmacists standby in emergency department. But the patient is the proportional of the pharmacist and the patient is not balanced.
Yes,
Yeah.
exactly. So yes, exactly. Even when I was conducting some research in Ethiopia, I have also encountered the same case. Emergency, yes, it's difficult because still patients stay there for shorter time. They don't stay longer there. So you may miss it even, you may miss patients. They are already maybe admitted inpatients already. So that's also the challenge, taking medication history at the level of emergency department, unless there is an embedded pharmacist. If there's an embedded pharmacist in the emergency department, still it's possible to conduct. But if it's like an ad hoc kind of service, it's difficult to catch up patients at the level of emergency department. So in such a case, what we were doing is that to do, during normal medication review services in the inpatient, still you can check what kinds of the medication the patient was taking at home. Still you have the possibility to check in the inpatient service. So yeah, it depends on the resource anyways. It depends on the resources and policy as well. But the two areas are very important in terms of quality or continuous use of medicines.
Thank you.
Yeah, no problem. So how frequent is a pharmacist involved in medication reconciliation in Indonesia? Is there any? I mean, pharmacists are well embedded in the hospital for medication reconciliation or medication review?
It's one of part of the accreditation of the hospital.
Oh, that's interesting.
Yeah,
that's interesting.
the accreditation. What is accreditation in English? The for sorry, wait.
Okay. Okay, that's interesting. Anyways, if it's part of a standardization process, I think yes, healthcare managers will take that into consideration for pharmacists to conduct medication reconciliation and review. Okay, so the other types of medication administration errors, yeah, these are another group of errors, medication administration errors. So this is it's all about errors occur during the medication administration, like wrong drug given to wrong patient, timing error, drug dosing error, concentration error, infusion rate error, and administration technique error. So a number of errors associated with administration. So these are the 5 rights of drug administration. Usually, the 5 rights are very important for nurses with respect to injections, but at the same time for pharmacists as well when we during dispensing. Okay. Okay, we do have patient case on medication administration errors. Have read this patient case and we'll have a question on this. So here the main point is that the doctor injects 10 ml of syringe, which is adrenaline, but he thinks that it was normal saline. Okay, remember this one. The epinephrine or the adrenaline preparation was done by the nurse, but unfortunately it was it was the doctor who used this 10 ml syringe of adrenaline. Then the doctor didn't communicate with the nurse what the syringe it is. I mean, what's the element within the syringe it is, but he thinks it's normal saline, and he uses that for the patient. The doctor gives all 10 ml of this adrenaline. The patient suddenly feels terrible, anxious, becomes tachycardic, and then becomes unconscious. She is discovered to be in ventricular tachycardia. Recommended dose for anaphylaxis 0.3 up to 0.5 milligram intramuscular. This patient received 1 milligram IV. So a number of errors have been occurred. Okay. So what are the causes for this error? What are the contributing factors for this error? Lack of communication, inadequate labeling, giving a substance without double checking, lack of care with important medication, or all. Yep, it's all of them. All of them are the reasons for this error to occur. Thank you so much. Okay, let's come to medication review. I bring this topic, medication review. It's not, it's a strategy, okay? It's a strategy because medication review and medication reconciliation are very related practices. They are very related practices, important for identifying drug-related problems, any medicine-related problems, but each have their own function. Medication review have its own function. Medication reconciliation have its function. The basic difference is that without medication reconciliation, you can't conduct medication review, because without having the right medicines at hand, you can't conduct medication review. So the medication reconciliation is a foundation. It's a background. It's a foundation for medication review. So in general, medication review is defined as a structured evaluation of a patient's medicines with the aim of optimizing medicines use and improve health outcomes. So it's all about minimizing medication-related problems, like medication-related hospital admissions, falls due to inappropriate prescribing. So the outcome here is that it is medication-related problem. It may be, it may have a number of terms: medication-related problem, drug-related problem, drug therapy problem. Whereas the outcome for medication reconciliation, what's the outcome for medication reconciliation? The outcome is medication discrepancies. Yeah, medication discrepancies. For medication reconciliation, it is because it's all about medication history, something like that. So you are checking whether there are differences between the medicines the patient is taking with the available resources. So medication reconciliation identifies medication discrepancies. Medication review identifies medication-related problems. So this is the main difference. Oh, sorry. Still, medication review have a number of synonyms. Different synonym words are there for medication-related for medication review. Some people use medication therapy management. Some people use, actually, it also depends from country to country. For example, MedCheck, it's Australia name. Polymedication, I think it's from Switzerland. Clinical medication review, it's common name in the literature. Residential medication management, medication use review, MUR. So a number of terms, synonym terms for medication review are there. What you call in your country? Is there any kind of medication review services or pharmaceutical care or clinical pharmacy services? What do you use as a term or as a term in your national framework for conducting pharmacy services? No? Okay. Let's go to medication review, the process. Yes, medication review, as I told you, has a number of stages to follow. The first is prescription order review, then chart review, adherence check, and comprehensive review. So medication review is by far an extensive process. It's a very extensive process. It needs specialized service. It's kind of specialized service because it needs a specialized skill set. It needs a coordination of activities because it also needs to, for example, contact the patient, contact the nurse, the physician. You have to know the patient's case. You have to know the disease states. So it needs specialized knowledge to conduct medication review. Medication reconciliation by far is easier because it's all about identifying the gaps in the information or in the continuity of whether there is continuity or discontinuity. It's about system. So medication reconciliation by far is the easiest to implement as compared to medication review. That's what I did while I was in Ethiopia. People easily accept your intervention when it comes to medication reconciliation, but physicians don't accept easily when you say this patient has this medication related problem. No, they don't accept you easily. But from the point of medication reconciliation, it's easy for even people to persuade, to convince them. So because this process needs a number of things. As I said, the complex medication review requires partnering with patients' carriers. It's a multidisciplinary approach. It needs medication reconciliation, suitable skilled clinicians. Yeah, suitably skilled clinicians. Normal individuals can't do this one. Normal, a person without any previous knowledge of patient management can't do this service. Okay, so yeah, it's a comprehensive step. Anyways, comprehensive step, like gathering information, just checking the patient's goals. I'm not sure whether you have learned about pharmaceutical care or not. In the pharmaceutical care, there are steps. So you should follow those steps to conduct medication review, assessment, care plan development, future and care planning. So these all steps, like nursing care or what you call patient care. Pharmaceutical care is normally in the pharmaceutical care aspect. What you do is medication review. So in the pharmaceutical care, we conduct medication review. So it's like almost comparable with what nurses are doing, although a different perspective, what physicians are doing, although in a different perspective. So this is kind of a specialized service. So let's come to, this is the main topic actually. Still now we try to explore patient safety, the history of patient safety, the causes of medication errors, types of medication errors, some examples, and then let's come to pharmacist role in patient safety, which is the main focus of this lecture. So as you know, all healthcare professionals, we all have a role in safety. Patient safety is not a role devoted to only to pharmacists, but it is a role employed by a number of factors, including us and other healthcare professionals. So our pharmacists are part of that. They're part of that. So what's our unique role? We do have our unique role. Although all have a role in patient safety, but we have also our unique role in patient safety. It is because we are medication safety experts, or we are pharmacists, meaning that we do have our own skill set, specifically on medicine selection or checking medicine safety. So these issues are unique to pharmacists. So we can still contribute a unique role in the healthcare system, so that we are part of the healthcare system, which we contribute a unique role. So these are some of the unique role for pharmacists, including medicines reconciliation, medicines optimization, checking medicines availability, ward dispensing. So yeah, these are unique role for pharmacists. But don't forget, still, teamwork is an important part of the patient care. So we are not doing alone, but we still communicate with a number of healthcare professionals. So let's come to pharmacist role in medication reconciliation. Pharmacists are frequently integral to the medication reconciliation process, but also it's not easy process because, as I said, it's a resource extensive process. It's a resource. Excuse me, can I make my light on? I think it becomes darker and darker. Sorry. So here, pharmacists may be integral to the medication reconciliation process, but the problem is that it's very resource-intensive process. It needs pharmacists to be placed on different transitions. This means that there may be some competing priority for pharmacists, for example, in the ward or maybe in the dispensary. So in such situation, we need an extra resource. So in such a way, it may be difficult to implement hospital-wide medication reconciliation. It may be difficult. But at times, it may be possible by targeting high-risk patients only. You may not conduct for every patient, but maybe that's one approach. The one approach is to target only high-risk patients, specifically, for example, patients taking 5 and more medicines, for example. You may conduct medication reconciliation because conduct for every patient is resource intensive. So what is the evidence for pharmacists in medication reconciliation? These are some of the studies I've conducted as part of my PhD. So the first is pharmacists can able to reduce medication discrepancies by 66%, whether at admission, whether at discharge. Irrespective of the care transition, they can reduce medication discrepancies by 66%. This is the first systematic review I have conducted. As you know, medication discrepancies are process outcomes. They don't show you hard outcomes. They are process outcomes. They don't show you whether those discrepancies cause patient harm or not. Yeah, they don't show you the real problem. So I have also checked whether these medication discrepancies have an impact on some patient outcomes, some clinical outcomes like hospital readmission, mortality, or adverse drug events. So the results shows yes, it is. Pharmacy medication reconciliation programs can result in a decrease in medication-related readmissions and reduction in emergency department visits. So these are very important findings. Another study I have conducted for, actually this is in a resource limited setting. That's a study from Ethiopia. So I have conducted a pre-post study at emergency department. So, implementing a medication reconciliation service at emergency department resulted in a reduction in medication discrepancies. Prevalence of at least one unintentional medication discrepancies was approximately 70 times higher in the absence of pharmacist interventions. Actually, I didn't conduct whether this has an outcome on another outcomes like hospital readmission. I didn't check it, but I checked only the process outcomes. A role of pharmacists in medication review. Yeah, with this, as I said, medication review is a little bit broader than medication reconciliation. So there are a number of evidences in the literature showing that pharmacists have an impact on medication. An impact from medication review. For example, the first review shows that drug-related admissions reduced by 75% when conducted by pharmacists, and all-cause emergency department visits by 30%. So this is a very important finding. It's a very important finding. Another in the community, that's community pharmacy-led medication review programs, result in a decrease in blood pressure in patients with diabetes, a decrease in diastolic blood pressure in patients with diabetes, and in hypertensive patients overall. Even in glycosylated hemoglobin in patients with diabetes, total cholesterol. So these are markers. Yeah, these are surrogate markers. So whatever in the hospital level or in the community level, pharmacy medication reviews can result in important clinical and process outcomes. Another is pain management. Even in chronic pain management, pharmacy medication review can result in a reduction in pain intensity. This is another finding. Pharmacists can reduce treatment costs for every dollar spent by hospitals or healthcare systems. There's a saving of $4.81 through lowering drug costs, reduction in adverse drug events, medication errors, and other savings. So for every $1 spent in clinical pharmacy services, there's a gain of $5. So the cost to effective, the value for money is higher. How can pharmacists contribute to, can contribute in reduction of medication errors? Let's see some findings from the literature. For example, the first review, impact of pharmacy intervention. This is the recent study on medication errors in hospitalized pediatric patients, shows that pharmacy involved results in significant reductions of medication error occurrence by close to 70%, almost 70% reduction in medication error. Another systematic review still conducted, I think this is 2 years back, it's a 2 years back study. Whether educational interventions, this is normally interventions. This is normal interventions, meaning that there's a close engagement of pharmacists within the healthcare team to conduct this intervention for the first one. The second systematic review is all about education. It's educating healthcare professionals, what it brings, pharmacy educational interventions on healthcare providers. Does it really affects medication error? This study shows that yes, it shows. Educational programs led by a pharmacist were associated with significant reduction in the overall rate of medication error. That's by around 60%, a 60% reduction a 60% reduction in error rate. So this is very important studies. This is all about I have. If you have any questions, you are all welcome. Any questions? Today we finish early. Okay, I guess yeah, I can send the slides to Andy maybe so that you can request him. Or else I think it's also recorded, I guess. If there is a possibility to get it from the coordinators, I am happy for them to send them to you. Any other questions? What's next? Do you have evaluation for this course outline? I mean, for this course overall, or how are you going to be evaluated? Or no evaluation for this course? Okay. So
To Mr. Andy, maybe.
okay. So Andy will give you assignment. How is the system works in your? I mean, how is the master's coursework works? Is that the kind of just take the course and go forward?
Sometimes the lecturer give a assignment, or in
Okay.
the end give the exam maybe.
Okay. So Andy may ask me to forward some questions or some kind of assignments, maybe. That's great. Thank you so much, guys. So yeah, thank you so much. And I hope we'll have some more opportunities for further discussion, whatever research purpose or for some other even lecture. Are you second year or first year?
First year.
First year, okay. So we may have some more opportunities in the future to have more discussion on other courses actually. Thank you so much. Have a nice time. And is there any coordinator here, or I'm gonna stop sharing? No person on behalf of Andy?
Thank you very much, Dr. Alex.
Okay, thanks so much. Okay.
See you
No
in
problem.
another agenda, maybe.
Okay, no worries. Just let Andy know that I have completed my course, and
Yeah.
and I am ready for any responsibilities.
Yeah, maybe Dr. Andy will contact you soon. Thank you
Okay.
very much.
Okay, no worries. Thank you so much, and have a nice time. Bye-bye.
See you. Have a nice day.
Thank you. Bye.
Thank you, sir.
Bye. Thank you.
Untuk absennya ada ya?
Oh iya, sebentar ya. Absennya
Iya, yang kedua belum.
sebentar. Ya mungkin bisa diisi untuk absensinya. Terima kasih.
Iya, terima kasih.